In 1 out of every 1,000 surgeries, the patient's eyes are closed. Their body is completely paralyzed, but their brain is wide awake. They can hear the surgeon talking. They can feel pressure, sometimes pain, but they cannot move. They cannot scream. They cannot signal that they are conscious. This is called anesthesia awareness, and it is one of the most terrifying experiences in modern medicine. Now, if you've ever had surgery, or if you're about to, you've probably wondered what actually happens in that gap, that dark space between count backwards from 10 and waking up in recovery. Where did you go? What happened to your body? And who was keeping you alive? In the next 17 minutes, I'll walk you through every single step of general anesthesia, from the drug that erases your memory before you even reach the operating room, to the machine that breathes for you, to the exact moment your brain comes back online. And at the end, I'll show you 5 specific things you can do before any surgery to make your anesthesia significantly safer. Number 4 is the one most patients never think about. But first, let me show you what happens 30 minutes before you fall asleep. I'm Dr. John Meyer, specialized in senior health with over 15 years of dedicated clinical experience. I have worked with thousands of men and women over 60, many of whom needed surgery and came to me with one question: Doctor, will I wake up? Before we go further, please subscribe and hit the like button. Not for me, because this information needs to reach the people who actually need it. And YouTube will only show this video to them with your support. This is exactly the kind of thing my patients bring me, one part of their health after another. So I took everything I tell my own patients and put it into one simple plan for living longer, stronger, and healthier after 60. 28 of the things that actually change as you get older: your blood pressure, your blood sugar, your memory, your balance. And those are only some of them. Thousands of people are already using it. It's already helped so many of them live their best life after 60. The link is on your screen right now, so go check it out at drjohnmeyer.com. I put the link in first comment too. Most people think anesthesia starts when you fall asleep. It doesn't. It starts in a preoperative room with a small injection into your IV line, a drug called midazolam. It belongs to a family of sedatives called benzodiazepines, and it does something extraordinary. Within minutes, your anxiety begins to melt away. You feel warm, calm, almost euphoric. Nurses might be talking to you. You might be joking with the surgical team, and you won't remember any of it. Reeves and colleagues documented this extensively. Midazolam causes what is called anterograde amnesia. That means your brain stops recording new memories. Everything that happens after the injection, the wheeling through corridors, the bright lights of the operating room, the faces of the surgical team, your brain simply does not store it. Think of it like this. Imagine your memory is a camera. Midazolam doesn't erase old footage. It presses pause on the record button. You are awake. You are talking. You are functioning, but the tape is not rolling. And this is by design, because what comes next is a process that the human mind was never meant to witness. Because 30 minutes later, a white liquid enters your bloodstream, and in 8 seconds, everything goes dark. You're lying on the operating table now. The room is cold, the lights are bright, monitors are beeping. An oxygen mask is placed over your face. And here's something critical. That oxygen mask is not just for comfort. Your anesthesiologist is flooding your lungs with pure oxygen right now, because in less than a minute, you will stop breathing on your own, completely. That stored oxygen in your blood is your safety reserve, your lifeline. Then through your IV comes propofol. It's a white, milky liquid. Some doctors call it milk of amnesia. You may feel a brief burning sensation in your arm. It lasts 2 or 3 seconds, and then in 8 to 10 seconds, your consciousness shuts down. Sahinovit's research group documented the mechanism in the British Journal of Anesthesia. Propofol doesn't just make you sleepy. It enhances a neurotransmitter called GABA, which acts like a chemical brake on your neurons. Within seconds, the communication between different regions of your brain is severed. The frontal cortex goes quiet. The thalamus disconnects from the cortex. This is not sleep. When you sleep, your brain is still active, dreaming, processing, cycling through stages. Under propofol, your brain is chemically silenced. The pattern on an EEG monitor looks closer to a coma than to sleep. Some researchers describe it as a state near death. Your brain is not resting. It has been switched off. And now, your body faces a problem, because the same system that just silenced your brain has also silenced the part of your brainstem that tells your lungs to breathe. And this is where the anesthesiologist's most critical job begins, because for the next 30, 60, 90 minutes, a machine will breathe for you, and someone must control every breath. The moment you lose consciousness, your anesthesiologist performs one of the most technically demanding procedures in medicine, intubation. A laryngoscope is inserted into your mouth. The vocal cords are visualized, and a plastic tube is guided through your throat, past your vocal cords, and into your trachea, your windpipe. That tube is then connected to a ventilator, a machine that will push air into your lungs and pull it back out at a precise rate, a precise volume, a precise pressure for the entire duration of your surgery. But there's another challenge. During surgery, the surgeon needs absolute stillness. If a patient reflexively coughs or their abdominal wall suddenly tightens during a delicate incision, the consequences could be devastating. This is why paralytic drugs are administered, neuromuscular blocking agents. These medications interrupt the signal between your nerves and your muscles completely. Every voluntary muscle in your body goes still. Your arms, your legs, your diaphragm, your chest wall. You are, from a muscular standpoint, completely frozen. Let me tell you about a patient, Thomas, 68 years old, needed open heart surgery. He told me the night before, "I trust the surgeon. It's the part where I'm not here that terrifies me." I told Thomas what I'm about to tell you. During every second of his surgery, an anesthesiologist was sitting at his head, watching 5 screens, monitoring his blood pressure, heart rate, oxygen saturation, carbon dioxide levels, body temperature, and anesthesia depth. Every 30 seconds, a micro adjustment, a fraction more anesthetic gas, a slight increase in ventilator rate, a small bolus of fluid. Hundreds of tiny decisions over and over for hours. The surgeon fixes the body. The anesthesiologist keeps the patient alive. Are you or someone you love facing a surgery soon? Type yes or no in the comments, because the information in the next section could help you prepare better than most patients ever do. Now, what happens when the surgery is over? Your body has been paralyzed. Your brain has been shut down. Your lungs have been run by a machine. So how exactly do you come back? When the surgeon closes the final suture, the anesthesiologist begins a reversal process. The anesthetic gases are turned off. Your lungs, now ventilated with pure oxygen, begin to clear the remaining anesthetic from your blood. Your liver starts metabolizing the drugs, and slowly, traces of electrical activity reappear on the brain monitor. Think of it like a city after a blackout. The lights don't all come on at once. One block, then another, then a neighborhood, then a district. Your brainstem comes online first. The most primitive functions, breathing drive, gag reflex, then the limbic system, emotions, orientation, then the cortex, higher thought, recognition, memory. This takes minutes, sometimes 5, sometimes 15. It depends on the drugs used, the duration of surgery, your age, your metabolism. As consciousness returns, the anesthesiologist watches for one critical sign: spontaneous breathing. The moment your diaphragm starts to move on its own, the moment your lungs begin pulling air without the machine, that is the signal. The endotracheal tube is removed. This process is called extubation, and it is uncomfortable. Patients may cough, they may gag, their throat will feel sore. But here's the remarkable thing. Because of the midazolam and the residual anesthetic effects, most patients do not remember this moment. The coughing, the gagging, the disorientation, it's as if it never happened. But for some patients, the waking process is not smooth. Some patients wake up in a state of severe confusion, agitation, even aggression. They may try to pull out their IV, they may swing at nurses, they may scream. This is called emergence delirium. Lepus et colleagues documented this in the British Journal of Anesthesia. It's more common in certain demographics, after certain types of surgery, and with certain anesthetic agents. It is temporary, it is manageable, but it is deeply unsettling for both the patient and the family. The patient rarely remembers it, but the family never forgets it. But now I want to address the question that every patient is truly afraid to ask. What if you wake up during the surgery? What if your brain comes online while your body is still paralyzed? Let's talk about what scares people the most: anesthesia awareness. Sabel and colleagues conducted one of the largest studies on this phenomenon, published in Anesthesia and Analgesia. They found that intraoperative awareness occurs in approximately 1 to 2 out of every 1,000 cases. That means in 998 out of 1,000 surgeries, it doesn't happen. But when it does, the experience can be traumatic. Patients report hearing voices, feeling pressure, in rare cases, feeling pain, all while being completely unable to move or communicate. Now, how does modern medicine prevent this? The answer is on the anesthesiologist monitor. Mashur's team at the University of Michigan conducted the landmark Michigan Awareness Control Study. They demonstrated that brainwave monitoring, using a technology called BIS, bispectral index, or processed EEG, can track the depth of anesthesia in real time. The BIS monitor shows a number between 0 and 100. 100 means fully awake. 40 to 60 is the target range for general anesthesia. Below 40 means the anesthesia may be too deep. The anesthesiologist watches this number constantly, adjusting the dosage, maintaining that narrow band between too light and too deep. Too light and the patient may become aware. Too deep and the cardiovascular system could be compromised. It's a balance, a continuous dynamic balance, for the entire duration of the surgery. Now let me give you a number that should reassure you. Lee and colleagues published a meta-analysis in the BMJ. The risk of dying from anesthesia in a modern hospital is between 1 in 200,000 and 1 in 300,000. Let me put that in perspective. Your risk of a fatal car accident on the drive to the hospital is statistically higher than the risk of dying from anesthesia. Modern anesthesia is one of the safest medical interventions in existence, not because the drugs are without risk, but because the monitoring, the training, and the precision have reached an extraordinary level. Now here's the part I promised you at the beginning, the 5 things you can do to make your anesthesia safer. Number 1, disclose every medication and supplement. This includes over-the-counter pills, herbal supplements, vitamins, fish oil, St. John's wort, even CBD oil. Many of these interact with anesthetic agents. Some affect blood clotting, some affect how your liver metabolizes drugs. Your anesthesiologist needs the complete picture. Number 2, be honest about your alcohol use. This is not a judgment, it's pharmacology. Chronic alcohol use changes the way your liver processes anesthetic drugs. Patients who drink regularly may require higher doses, and if the anesthesiologist doesn't know this, the dosing may be insufficient. Number 3, follow the fasting instructions exactly. You will be told not to eat or drink for a specific number of hours before surgery. This is not a suggestion, it is a safety protocol. If your stomach has food in it during intubation, that food can be aspirated into your lungs. Aspiration pneumonia is a serious, potentially fatal complication. Number 4, ask about your anesthesia plan. This is the one most patients never think about. You have the right to meet your anesthesiologist before the procedure, and you should. Say this to your anesthesiologist, word for word. I'd like to understand the anesthesia plan for my procedure. What agents will you use? Will BIS monitoring be available? And what is your protocol for managing awareness prevention? Those exact words will be recognized immediately, and they will ensure that your anesthesiologist knows you are an informed patient. Number 5, report any previous bad reactions. If you've ever woken up with severe nausea, if you've had an allergic reaction to an anesthetic, if a family member has ever had a complication with anesthesia, this information is critical. Some anesthetic sensitivities run in families. The medical term is malignant hyperthermia susceptibility, and knowing about it in advance can save your life. That's your checklist, 5 steps. Print them, write them down, take them to your pre-surgical appointment. I want to leave you with this thought. Every day, over 60,000 people in the United States alone go under general anesthesia, and the vast majority of them have no idea what is happening to their body. They don't know about the memory erasing drug. They don't know that a machine breathes for them. They don't know that their muscles are chemically paralyzed. They don't know that every 30 seconds, someone is making a micro decision to keep them alive. Now, and knowing doesn't make surgery more frightening. It makes it less frightening because fear comes from the unknown, and you just replace the unknown with understanding. Type 1 of 3 things. Sharing this, if you're sending this to someone who has a surgery coming up, your question about anything I covered that you want more detail on, or thank you, because every comment helps this video reach someone who needs it. This video is for educational purposes only and does not replace your doctor's advice. Never stop or change your medication without consulting your healthcare provider. Everything I've shared here is general medical information. It is not a substitute for your personal medical care. Please talk to your own physician. That's not a legal disclaimer. That's genuine advice from someone who wants you still watching this channel 10 years from now. I'm Dr. John Meyer, specialized in senior health. Thank you for watching, and I'll see you in the next one.